Greetings and welcome to this video on influenza approach for physicians. The part 1 video we have already been uploaded. This is the part 2 where we discuss about the do's and don'ts and how to approach an influenza infection and when does the rapid test is negative and when to diagnose influenza and the vaccination part of influenza. This is completely for educational purposes. This is Medicine Beyond Harrison. Let's get started. So when to suspect, even if the test is negative, we have to suspect influenza. In what cases? So the rapid antigen test is a less sensitivity test. That is just low sensitivity. So a negative test does not rule out influenza. So you can start treating influenza empirically when there is a strong exposure. That is when the patient is exposed to a influenza positive patient in the recent days, and there is a high local prevalence plus the presence of classic symptoms of influenza. To know about classic symptoms of influenza, we have already uploaded a video on influenza virus part 1. Do check on that. In critically ill patients like in ICU admissions and patients presenting with ARDS, it is better to treat influenza. So clinical judgment trumps a negative rapid test in high prevalence settings. So that is a take home point. So red flags for immediate hospitalization. So when there is a respiratory failure with SpO2 of less than 94% on room air, when the respiratory rate is more than 30 breaths per minute, and if there is presence of chest pain, which suggests influenza myocarditis. So when there is systemic collapse such as hemodynamic instability with low BP, altered sensorium confusion, inability to maintain hydration, the clinical course of influenza is usually biphasic. There will be worsening after the initial improvement. So it is better to admit and treat. So pregnant women with severe symptoms. The secondary bacterial pneumonia, common pathogens are Staphylococcus aureus, including in MRSA. So, yeah, when an influenza patient gets readmitted with similar lung infection, always suspect Staphylococcus aureus and also MRSA, and also suspect Staphylococcus pneumonia and Haemophilus influenza. So, one of the risk factors for MRSA is Staphylococcus aureus. So, clinical clues for secondary bacterial pneumonia is the biphasic course. In the initial improvement, when the influenza is getting treated, and then sudden worsening due to secondary bacterial infection. There will be recurrent fever. High grade fever returns after 3 to 5 days of initial infection. Sputum may become purulent rather than the initial whitish ropey kind of sputum. Now it becomes purulent. Chest X-ray may show multifocal consolidation. Treat early. The mortality is reduced significantly. So special populations and key adjustments. In pregnancy, Oseltamivir is safe and recommended. In children, avoid aspirin because of increased risk of Ray's syndrome. In renal failure, must adjust oseltamivir dose based on the GFR. You can either give 75 mg of oseltamivir once daily or 30 milligrams of oseltamivir twice daily. It is available in both these formulations. In case of asthma and COPD, avoid zanamivir, high risk of bronchospasm. In case of immunocompromised, like, these patients have longer viral shedding, so may require longer treatment duration than the standard 5 days regimen. So, when to extend the standard 5-day treatment regimen of influenza, that is beyond 5 days, when to treat it, you can even treat it up to more than 10 days. So, in case of critically ill patients in ICU, in case of severe disease like severe pneumonia and ARDS, in case of immunocompromised states, and ongoing viral detection by PCR, lab evidence of ongoing viral detection by PCR. The decision is based on clinical judgment rather than laboratory parameters. So, steroids and co-infections. So, are steroids harmful in influenza? So general rule is to avoid in uncomplicated influenza. It worsens the outcomes. So there are few exemptions. Use only if there is septic shock and the patient is on vasopressors. It is useful as a stress dose of steroids. In case of suspected adrenal insufficiency, in case of asthma, COPD exacerbation, in specific indications such as vasculitis. So the diagnostic puzzle mimics and coexists with the dengue, COVID-19, respiratory syncytial virus, and leptospirosis. So the main clue is from the CBC. There will be lymphopenia in case of influenza. So there will be thrombocytopenia and hemoconcentration in case of dengue. And hyponatremia if it is present, then consider Legionella. Protocols, hospital protocols, the staff should be vaccinated. More than 90% of the staff should be vaccinated and prevents the outbreaks. Isolation, the droplet plus contact precaution should be early. So you have to wear an normal mask and contact precautions early. Triage, mask all symptomatic patients, and the procedure avoid nebulization unless absolutely necessary. So it will result in increased aerosol production and may result in spread of the virus. So antiviral resistance suspect when worsening symptoms despite 40 to 72 hours of treatment and in immunocompromised host. So there will be oseltamivir resistance in H1N1 because of a mutation in H275Y mutation. So in this case, switch to zanamivir or peramivir. So vaccination, inactivated vaccine is present. There is a live attenuated vaccine. So inactivated vaccine is usually used. It is a whole virus, a split virus, and subunit. All these types of vaccine are available. It is most widely used. It is introduced since 1940s, and there is also a live attenuated vaccine which is used as a nasal spray in healthy non-pregnant up to 50 years of age, that is up to 49 years of age. Contraindications are pregnancy, chronic illness, and antiviral use within 48 hours, as its efficacy as well as the safety is not clinically judged, or there is no evidence RCTs to show its clinical safetiness in these patients. So formulations is trivalent vaccine and a quadrivalent vaccine are available. In trivalent, there are two influenza H1N1, H3N2 subtypes plus one influenza B subtype. In case of quadrivalent, two A strains and two B strains are available. So guidelines, as per the Ministry of Health India, children's 6 months to 8 years can be vaccinated. Elderly more than 65 years should be vaccinated. In case of pre-existing lung disease such as COPD and asthma should be vaccinated. In case of other comorbidities such as heart disease, diabetes, and any other chronic illnesses, these patients should be vaccinated to prevent a severe influenza infection. So general practical recommendations as well as Association of Physicians of India recommendations are annual quadrivalent vaccine with the latest strains are to be administered in all the at-risk patients. Prioritize high-risk categories in elderly more than 65, healthcare workers, pregnant women, and adults with chronic illnesses. So these are the complete vaccine references. There is a whole inactivated vaccine which is given IM for all groups. High seroprotection is there and higher reactogenicity. There is a split vaccine, there is a subunit vaccine, there is a high dose inactivated vaccine also available. Whereas the high dose is only given in more than 65 years. It has a better immune response and it's not given in younger people. The subunit vaccine is highly purified because of which it is costlier. And the live attenuated vaccine is also available, which is given intranasally. It is a needle free. The advantage it is needle free, and the cons it is avoided in asthma and pregnancy because its efficacy and safety is not proven. So it is given only up to the age of 49 years. Thank you. Hope you learned something in influenza and we'll go forward in learning other things in this infectious disease module.